Before I talk about CHAMP Plus, I just want to remind us why adolescent-friendly programming is so critical. We have all heard about the hundreds of thousands of adolescents living with HIV. We know that they are a high-risk group for poor health outcomes and non-adherence. And we also know then that addressing their needs is a significant public health challenge. Importantly, we also heard yesterday that there are 2.1 million children under the age of 15 estimated to be living with HIV, the majority perinatally infected, ensuring an adolescent epidemic for years to come. We have great medicines for promoting their health. We know that's not the issue. But the strongest barriers to actualizing the potential of those medicines are behavioral, psychosocial, or contextual. And this is particularly true for adolescents. So to give you a sense of this risk in the US, in a cohort study of perinatally infected young adults we've been following for 14 years in New York, the majority actually are showing resilience, meeting educational or work milestones. But 50% are not virally suppressed, and over 40% are living with psychiatric and/or substance use disorders. So unfortunately, there are few evidence-based interventions to promote adherence and mental health, and these two have been consistently associated with each other in the literature. We do know from other areas of adolescent research that prevention of health-impairing behaviors, such as condomless sex or substance use, before those behaviors begin is much more effective than intervening after behaviors established. So waiting until young adulthood is perhaps too late. So CHAMP Plus was developed to promote health and mental health and prevent risk behaviors in perinatally infected early adolescents before risk behaviors emerge when they are still connected to caregivers and providers. CHAMP Plus is based on the collaborative HIV/AIDS Mental Health and Prevention Project, otherwise known as CHAMP. It was developed by my colleague Mary McKay in Chicago. It's an evidence-based intervention supported in multiple NIH-funded clinical trials in the US, South Africa, and Trinidad. It was created by clinicians and stakeholders working with researchers to help HIV-negative youth and their families. Its goal is to prevent health risk behaviors and promote mental health in young adolescents living in vulnerable communities. The way it works is that multiple families, say 8 to 10, come together in the communities for 10 sessions to share a meal and participate in separate individual and caregiver combined groups on a semi-structured curriculum. Youth and caregivers have separate needs, but they also need to work together. So those sessions are typically focused on strengthening parent-child communication and family decision-making, helping parents take leadership in all aspects of family life that offer youth protection, such as supervision and monitoring, increasing youth self-esteem, social problem-solving, and peer negotiation skills in situations where sexual risk or substance use are possible, increasing knowledge of HIV transmission and prevention methods, and then finally, increasing social support within and between families to really support young people. CHAMP Plus can be facilitated by lay staff, which is really key to promoting capacity in resource-constrained contexts. So we thought CHAMP would be a great model for positive kids, especially since we thought it would also apply to adherence. And a key aspect of CHAMP is that for each new context, a qualitative phase is engaged in with consumers and key stakeholders to ensure that the intervention actually meets the needs of the specific population and that it will be acceptable and sustainable as well as effective in those contexts. So that's what we did. To understand key psychosocial challenges and protective factors for the youth and their caregivers, we conducted a needs assessment with focus groups and interviews with the adolescents and their families. To develop a culturally and contextually appropriate curriculum, we collaborated with patients and providers to review the needs assessment and to think about if CHAMP was the right model and then how it would look. And then to pilot the new program and evaluate feasibility, acceptability, and preliminary effects, we conducted several trials in the US, in South Africa, and also in Thailand with young people in those clinics. And I'm going to talk about South Africa and Thailand briefly. So actually in CHAMP Plus, we have retained a lot of what was in CHAMP. Lay staff administer it. There are multiple family groups. And you can see here we retained a 10-session curriculum. What's in black is retained from the original CHAMP for negative youth. But obviously, young people living with HIV have their own needs. And so we added what's in green. In contexts that have been devastated by HIV, families needed to tell their stories and really deal with loss and bereavement. Adherence, in spite of the fact that these young people have been taking medicines their whole lives, they need to really think about and understand changing regimens, and providers need to work with them about how adherence fits into their lives at each stage of development. Obviously, identity is a critical issue, and acceptance of diagnosis, and then disclosure and stigma that we've heard so much about today, actually. In Africa and now in Asia, that 10-session curriculum is actually delivered via a cartoon-based curriculum, which provides a context for family communication about sensitive topics that in many contexts are either difficult to discuss or taboo. Participants actually explore the topics through the cartoon characters first, which then provides a safer environment for them to think about whether they want to talk about their own issues at those times. It also allows facilitators to address literacy concerns by providing a visual as they move through the curriculum. So in Africa, which is what you're looking at here, the stakeholders called the intervention VUCA, or Let's Wake Up. The story focuses on a 12-year-old boy, Temba, who has just lost his mother to AIDS and has already lost his father and goes to live with his aunt and uncle. To give you a flavor of the cartoons, here Temba's struggling with feelings of loss and bereavement. This is the very first session that he's mourning the loss of his parents, moving away from home and friends, having to live with people he doesn't really know, sleeping on their couch, and clutching a memory box that's been made for him. So youth and caregivers talk about how Temba feels and then what they can do. Temba's aunt figures out that maybe he should be tested for HIV since both his parents died. In fact, he has HIV. And so here he's learning about that. He's learning about the need to adhere to medication. And the nurse describes how the virus works, why adherence is critical, using actually South African created metaphors. Like many adolescents, Temba has a romantic interest. He struggles with whether or not to disclose to a girl he likes. And then finally, in one of my favorite cartoon strips, he struggles with what his identity is now. Here, Temba discovers that he's much more than an AIDS orphan or a boy living with HIV. He's someone's best friend. So again, youth talk about this and how it applies to them. In Thailand, stakeholders highly endorse CHAMP Plus as an important tool, and the cartoon curriculum is particularly important, particularly given some concerns around family communication and the need for young people to unconditionally obey elders that makes it difficult for them sometimes to voice concerns or disagreement. In Thailand, the families changed the title, like at VUCA. Theirs translates into Walking Together. Titles are important because they give clinics ownership of the material. They also changed the storyline. They wanted the cartoon to include an HIV-positive birth mother along with an HIV-positive adolescence. So here you see 12-year-old Tam. He's lost his father to AIDS. He lives with his mother and grandmother. And now his mother has a new boyfriend who initially doesn't know their diagnosis. I'm only going to show you one clip beyond the first one because this was a little bit different in Thailand than in Africa. In this story, Tam knows his diagnosis right from the start, but he is struggling with the loss of his dad and bereavement, similar to Africa and the US in our curriculum. But unlike the Africa version, in this version, the mom acknowledges his feelings, but emphasizes the need to keep a stiff upper lip, to focus on the positive and not give the dad a reason to worry. So in both South Africa and Thailand, as I said, we conducted pilot trials in pediatric HIV primary clinics. And as you can see here, the intervention, let's see if I can do this, was very well received in both contexts, with the majority of participants attending the majority of sessions. And while we were not powered in these pilots to test statistical significance, we did find some promising results. Compared to standard of care, VUCA participants had, see if I can show you, had significant improvements in self-reported adherence. And in Asia, compared to standard of care, the participants had higher rates of viral suppression at 9-month follow-up. We also found differences in some of the key individual and family secondary outcomes, including HIV treatment or transmission knowledge, better caregiver-child communication, and less perceived stigma, internalized stigma. So as we heard, that's very important this morning. Unfortunately, we did not find changes in mental health. So I want to end by just giving you a few of the lessons learned. We think from these pilots, CHAMP Plus or VUCA shows promise as a strategy for promoting adolescent health via a family and peer support intervention. CHAMP Plus uses a model that focuses on many universal themes related to adolescents, families, and HIV, but it can be tailored to context and delivered by lay staff, a task-shifting approach critical to resource-constrained settings. Challenges were disclosure. When young people don't learn their diagnosis till 13 or 14, they can't participate in this. But I will say, knowing CHAMP was coming into a clinic led to more disclosure there. There are a growing population of orphans who don't always have a caregiver to come in, and it's difficult to change mental health in short-term interventions. I think we all know that now, and we need to think about that. We are ending shortly a large-scale trial that includes the Thai pilot. It's based in Africa, so stay tuned. But to end, I think there are two key takeaway messages: the importance of starting behavioral health risk reduction interventions early, and the importance of involving youth, caregivers, and providers in all aspects of program development and evaluation to promote stakeholder investment, trust, ownership, and thus the potential for sustainability. It takes a village of collaborators, funders, and stakeholders to do this work, and I want to thank them all.